All right, welcome back to the podcast. I am joined with Emerald Norman. She is a fourth year medical student going into psychiatry at Loma Linda University, and we have been working on a project. She actually did some research in undergrad on expressive writing and mental health. And today we will be talking about writing to overcome trauma and improve mental and physical health. Um, we will be talking about some different studies. We'll be getting into the details. We'll be talking about how to develop your own practice of expressive writing, and also in cognitive processing therapy, there's some writing that they do, and we'll be talking about that. And we'll be talking about our own experience of trying this out. So, welcome to the podcast.
Thanks for having me, Dr. Peter.
So, yeah, do you want to kind of just share a little bit about your paradigm of expressive writing?
Yes, of course. So, one of the lead voices on expressive writing as a way of kind of dealing with trauma is Dr. James Pennebaker, PhD. He's done a number of studies that kind of look at expressive writing and how it can help in a variety of ways. He kind of got started after he started doing research surrounding on trauma disclosure and how and he found that people who disclosed their traumas um, were able to, one, move through them more effectively and to have benefits in both their physical and emotional health down the line. So he kind of is like the main leader in this field looking at expressive writing. And the idea is that when you write expressively, you're able to kind of vent and disclose that trauma, not hold it in. And that allows for, I guess, a decrease in stress. We talked about in a number of papers, there's a decrease in rumination, um, which has a connection with depression. So that's kind of the paradigm, the kind of
Yeah.
idea that you're writing, you're disclosing your trauma, and all of that is making it easier for you to both process the trauma and release that stress from your body physically.
Yeah. So I think that's a good intro. I've listened to actually some audio podcasts of him as well.
Hmm.
Um, and we looked at this paper that is from 1988, talking about, you know, did disclosure of trauma influence psychosomatic issues, and
Hmm.
specifically around childhood. They looked at people who had no trauma, who had trauma but confided that in other individuals, trauma, and did not confide it in anyone. And how big of a difference were those groups?
It wasn't that big of a difference, um, but it was a statistically significant difference. So, and that's something that I feel like, even in my own study that we found, when I was you talked a little bit about this, but when I was in undergrad, we looked at using Pennebaker's paradigm, expressive writing and the effect it has on state anxiety. And what we found is that it had a very, very, very small effect, really, but it was significant. And I think that's kind of the important part where it's like expressive writing is not the only thing that you should be doing, but it's a good adjunct to therapy or whatever other form of processing you're using to deal with your trauma. And that's the same thing that we find in this study. The difference in total illness, which is in the table that will be in the document, is pretty small, but it is statistically significant.
Yeah, so that the physician visits for illness with no trauma was like 1.14. If they had confided trauma, it was like 1.75. If
Mhm.
they had trauma but not confided, it was 2.0. So there were more physician visits, not a huge jump for people who did not confide, but it was higher. And so, as I've heard him talk about this on other podcasts, he'll say, like, therefore, writing can be one way of confiding.
Mhm.
And we'll talk about where there is an impact and where there is not maybe as big of an impact in writing. And we'll get to eventually talking about cognitive processing therapy and about how if someone has a high level of dissociation, writing actually helped them quite a bit. Maybe just as we begin, like what is expressive writing? Like what is a normal protocol in these studies? Just so we kind of have an idea of what we're talking about. Like what question do they ask? How long do they have them?
Okay,
Right.
so an expressive writing intervention typically is about based on Dr. Pennebaker's work. Other authors have kind of co-opted and changed it in whatever way they found most useful for their studies or for the way that they want to conduct therapy. But going off of Dr. Pennebaker's original work, he would have the participants write for 30 minutes, for 20 minutes over 3 days. And he asked them to write about their deepest thoughts and feelings around an emotionally disturbing event that they experienced in their life right now. And he also asked them to tie their topic in with past stressful or traumatic experiences, their relationships with others, how they relate to their parents, friends, relatives, and how it affects them in the past, in the future, in the present, how it affects their self-concept. So very kind of broad, abstract questions, but that encourage people to to think deeply and kind of have the freedom to take the writing wherever they would like to.
Great. Okay. Let's talk about this one article, the 2010 study by Joshua Smith, um, how expressive writing decreased anger and tension, but not PTSD symptoms. Let's talk about that study.
Yeah, so in this 2010 study by Joshua Smith, he used a very similar paradigm to Dr. Pennebaker in that he had his participants write for 20 minutes and do 3 sessions, but he had them all do it in one day, separated by 15-minute rest intervals. And he kind of separated within the prompts how he wanted them to write. So for the first prompt, he wanted them to identify and label the event with their thoughts and feelings. For the second prompt, he asked them to tell a story about the event and how it affected them. And then for that third prompt, after the last 15-minute interval, he had them reflect on what they had written previously and then retell their story with any new insights that they had gained from writing the previous 2 prompts. And they used the POMS, which is the Profile of Mood State Subscale, to basically measure changes in the mood states of tension, depression, anger, vigor, fatigue, and confusion. And they also used the PTSD symptom scale interview to assess for like PTSD symptom severity. And like you said, there was no change in PTSD symptom severity. The POM scores did decrease in 3 domains. So in the mood state of tension, depression, and anger, tension and anger decreased with a P of less than 0.5, and depression with a P of less than zero point 0.1, meaning, of course, that anger and tension were the only statistically significant decreases.
Yeah, so I think the the decrease was substantial in anger. It was around -6. In tension, it was around -5. And how many points were anger and tension out of for the total palms subdomain?
So for the total palm subdomains, anger was out of 48 and tension was out of 36.
Okay. So yeah, you can see that those drops were both statistically significant and probably substantial for just such a short intervention.
Mhm.
We're talking about 1 day, 1 hour riding to get some anger decrease is significant. They also looked at cortisol, salivary cortisol at baseline, post. Um, Anything interesting from that?
Yeah, so again, it was a pretty small uh, shift, but they did find a decrease in cortisol for the experimental condition by a measure of about 2 nanomoles. And while that's pretty small, we know that cortisol is an indicator of stress in the body.
Yeah,
So that means that this, 1 hour whining condition did decrease physical stress in the body.
a little bit, a little bit. It's
A little
like
bit, a little
a little bit, yeah.
bit.
Um, it doesn't get that. Honestly, the anger decrease, the tension decrease, that gets me somewhat hopeful that there might be more here, that we should look at this a little bit deeper.
Mhm.
Um, so okay, let's go on to cognitive processing therapy with writing or without writing. There's a very nice study by Patricia Resick. She was on my podcast a couple months ago. This is a 2012 study, and tell me about this one.
This study looked at CPT therapy in treating individuals who have PTSD. They measured the amount of PTSD symptom change, and they also measured dissociation in the population that they were studying.
Let's get a little bit granular with that 30 item multi-scale dissociation inventory. What were some of the subdomains of that, and how did they score it?
Yeah, so there were six different types of dissociative responses that they looked at. So the first was disengagement. Second was depersonalization. The third was derealization. The fourth was emotional constriction slash numbing. They also looked at memory disturbance and identity dissociation. And they indicated, the participants indicated on a scale of 1 to 5, or 0 to 5, 0 being never and 5 being very often, how frequently they experienced each item. And so, as a result, the higher their score was, that means the more dissociated they were.
Yeah, I think this is an interesting scale. Um, so they wanted to look at not only dissociation, but the different subdomains of dissociation. And they looked at it pre and post. And so, and in this study, just to let you, there's a randomized control trial of CPT, like the cognitive processing therapy alone, cognitive processing therapy with the writing portion, and just the writing portion. And we're going to talk about what those entailed in a little bit. But just to give you an idea, this was, pretty big study, pretty well done. As with all of Resick's studies, they're pretty fantastic in how they're done. So, okay, talk. Oh, and let's also talk about the PTSD, the post-traumatic diagnostic scale. What did you learn about that one?
Yeah, so we found that the post-traumatic diagnostic scale, it was made up of a 24-item self-report scale. So 20 of the items had to do with the 20 DSM-5 criteria for meeting like a PTSD diagnosis, and they had 4 additional items that addressed like the duration, symptom onset, and effect that PTSD had on the person's life. And a higher score, again, it was from 0 to 4, kind of commenting on the severity and frequency of what they were experiencing. So 0 would be I never experienced this symptom. 4 would be I experience this symptom 6 or more times a week, or I experience it severely. And a higher score would represent a more severe symptomology.
Perfect. I think it's valuable, and we were talking about this as we worked together on this project the last 2 weeks. I think it's very valuable, um, thinking through as we look at pre and post, and the types of ways that people were scored. Are the changes big enough to actually be clinically significant to me as a provider? So there's clinical, statistical significance, p-value less than zero point 0.5. This study shows that these two outcomes are different. There's only a 5% chance that they're not different. Okay. That's what that means. Um, and then there's like clinical significance. And so when I'm looking at a study, I'm thinking to myself, like, okay, do these change enough for this to be something that I would spend the rest of my life talking to my patients about and doing and training myself in? Because I don't want to do something that doesn't make sense. And so, as we read through studies, this is the me teaching medical students and residents, like look at the measures. We looked back at the measures. We looked at how they scored it. You could see in table one of this study how they show the means of the starting places of different things like the dissociation. And so you can also see kind of how sick people are that were brought into the study, right? Um, there was one study we looked at we did not include today, and they were looking at PTSD symptoms, but the scores were like super low. Like people did not enter the study with PTSD, but they were wanting the writing intervention to decrease PTSD. And yet there was no PTSD in the people that came into the study in the first place.
Mhm.
Um, okay, so these people came in with some dissociation scores that were the mean was around 64, 65, 61 for the different groups. So the other thing I look at when I look at a study is like, okay, were they randomized well? Like are the scores very lopsided one way or the other? Because then we're going to expect different outcomes in different groups just because of the lopsidedness in the scores, right?
Mhm.
Let's talk about what this study found, and then maybe we'll rewind to talk about what the different groups really did. Okay. So, what did this study find in regards to low dissociation and high dissociation?
Yes, okay. So the study basically tiered its participants based on their MDIs, like the multi-scale dissociation inventory scores into high dissociators and low dissociators. And uh, when they did their analysis, they kind of included that tiering, and they found that their PTSD diagnostic scale scores were about the same for people who had low levels of dissociation and kind of medium levels of dissociation. But for people who had high levels of dissociation, in kind of the post-treatment and 6 months follow-up, they found a significant difference in their scores. The most pronounced difference was found in kind of the subgroup of MDI depersonalization. So just looking at that one of those um, 6 factors of dissociative response. So for people who scored within the 2 standard deviations above the mean score for MDI depersonalization, they found PTSD scale values of 7.75 for those who were doing the CPT with the writing intervention, and 27.93 for those who were doing CPT without the writing intervention. So that's kind of a pretty big difference. So 775 versus 2793. And the only difference between the two being having written the account and having not written the account.
So, okay, let me repeat that in the way that I understand it, just basically saying the same thing again so people can hear it twice. Okay? So, in patients with high levels of depersonalization, like 2 standard deviations above the mean,
Mhm.
um, they they scored a lot better in the final analysis, like in their final time of checking in on them. They scored a lot better in their PTSD symptoms if they had the writing component and the cognitive processing therapy component. Okay. So it was the combination that was powerful.
Yeah.
Without the writing component, they scored a lot higher on their PTSD symptoms. Okay. Their score was around 7.7 if they got cognitive processing therapy with the writing. It was 27.9 if they got the cognitive processing therapy without the writing. That's a 1.12 standard deviation difference. And so this is where I start getting excited about like, okay, I think we found something really cool here. So in summary, what is, you know, the writing portion that they did in this cognitive processing therapy? What is the writing portion and how is it helpful? There were other things that we learned from the study, um, but I think I want to talk about like specifically what is cognitive processing therapy? What is cognitive process therapy with the writing? Okay.
Right. So, Dr. Patricia Resnick actually wrote out a manual for a CPT specifically for PTSD. The one I looked at was specifically for uh, v- veteran and military parti or patients, but I believe it's the same. It's
Yeah,
the same.
that it's she worked largely with that population, but I think she has said CPT actually works better outside of the military population because as we all who have worked in the VA know, often vets come with a number of comorbidities. But go ahead.
Yeah, but all that just to introduce where I'm getting this information from.
Cool.
In her manual, she basically wrote out what the writing intervention would be if you were to do the what they call the CPT therapy, not the CPTC, which is the non-writing intervention, but CPT. Um, so it reads, please begin this assignment as soon as possible. Write a full account of the traumatic event and include as many sensory details as possible. Include many of your thoughts and feelings that you recall having during the event. Pick a time and place to write so that you have privacy and enough time, and don't stop yourself from feeling emotions. If you need to stop writing at some point, please draw a line on the paper where to stop. Begin writing again, pick it to next session, etc. So basically, she's asking them to give a detailed event of what happened, and they're allowed to talk about their thoughts and feelings around the event. Yeah, but the main point is for them to include as many like details as possible. So I think this could actually be considered like um, an expressive writing intervention because she does encourage them, or the writer at least does encourage them to include as many thoughts and feelings that they have during the event, which is kind of similar to the prompt that Dr. Pennebaker gives us.
Here's a portion that I found interesting. So basically, session one of the cognitive processing therapy with the writing portion included an assignment to write an impact statement, is what they call it, about the perceived cause and the personal meaning of the index, the worst event, the worst trauma. Okay. And then after
Mhm.
reading and discussing the meaning of the index trauma in session two, patients were learning to identify relationships among the events, thoughts, emotions. This included worksheets. At the end of session three, patients were assigned to write a detailed account of the worst trauma, including the sensory details, thoughts, emotions. Um, and then patients were instructed to read the account every day. In session 4 and 5, patients were to read the trauma account aloud to the therapist, who assists the patient in processing emotion, challenging the maladaptive thoughts about the meaning of the events through a Socratic dialogue, and writing about additional traumatic events may occur in session 5, but the focus of CPT shifts to teaching the patient to challenge and change the beliefs about the meanings of the events and implications of the trauma in their life. So they're kind of challenging some of the cognitive distortions that may be there. And then in session 6, they are taught to identify problematic thinking that come to represent a style of responding to the trauma. So any guilt specifically, they would look at. Guilt was one of the things that Patricia Resnick talks a lot about. It's like it's just not helpful for someone to have any guilt about a specific trauma because that guilt kind of holds them and holds them from grieving and processing and moving through it. Okay. So you can see from this that the writing kind of like deepens some of the work. Um, it brings out some of the what meanings occurred, how they why they thought this trauma occurred specifically. Interestingly, in this specific study, which I highly recommend anyone who's interested in this read, interested in trauma therapy read. The third group was the writing only,
Hmm.
and it's like I think it's worth talking about this group because if you look at this study, these people got better too. Okay. So in the writing only protocol, basically they were told to write um, in the same way that I just described, but instead of the instructor challenging the beliefs, they would just more give like education, empathy, and so they were in these sessions writing instead of in therapy. And but they were going through a lot of the same questions. The therapist after that were hearing from the patient who was reading them to them. So it's not like they were just writing it with no response from a therapist. They were reading what they had written to the therapist. And the therapist would give them supportive comments, empathy, facilitate emotional processing, provide education, but not conduct any cognitive therapy or try to challenge the cognitive distortions. Okay. So you could see how that's very active. It actually, I would say, is a form of therapy. It's not just writing, and I think
Mm.
that's important to note because of how each group did get better. Anything else you'd want to add on to those two descriptions of the different groups, or anything
No,
jump out at you as different than expressive writing or
not particularly. I would say, I feel like you said it very well. You summarized everything very well. But it is very interesting that even without the kind of more active um, interpersonal forms of therapy, that people were still able to kind of breach that same ground and still improve a lot. So that's not new. I'm agreeing with you.
okay. So one of the things that they noticed in patients with higher dissociation. So when looking at patients with two standard deviations above the mean of this group, dissociation wise, they found that in those that were in the writing group, they had a faster decrease in symptoms.
hmm
Okay. They all kind of ended up at the same place eventually, um, but they had a faster decrease in symptoms. The second thing we've already talked about, but I think it's worth mentioning again, is that the depersonalization group had a more significant decrease in symptoms. And so depersonalization means, and I did a whole episode on this in the past. It's like someone who doesn't feel quite um, like they're like they don't feel like they're habitating their body anymore. They don't feel
hmm
like they're part of themselves. They feel distant from their selfhood.
mm
Okay. And so when I think about patients with depersonalization, I think to myself, these are people that they don't have like a narrative, a story for what happened and why they are feeling the way they are. And so I think there's something very powerful for this specific group to write out and just have it for themselves. This is what happened. Okay. This is the truth of my story. This is why I feel the way I do.
hmm Yeah, I agree. I feel like it gives them the chance to kind of tell their own story to themselves, which I feel like can just reintegrate them into their own personal narrative. Like they're at this place where they feel separate from what's happening to them. And this kind of allows them some synergy between what happened to them, what's happening to them, and accepting it, who they are, bringing it all together back into one story and allowing them to tell that story.
Yep. And interestingly, in the low dissociation group, the group that did not have the writing had a steeper slope of getting better faster.
Mm.
So in the low dissociation group, the writing could actually slow down progress, it seemed. Um, so I think that's worth noting as well from the study. So a lot of nice pearls from the study. Um, yeah, I think they all got better to a large degree. They all got better. So all of the groups got better. Okay. Any big pullaways from this study that you have? Any big things you want to just reiterate before we move on?
Mm, no. Is it okay if I say no?
Okay, that's good. Okay. So we'll keep going. Um, let's talk about this other clinical trial conducted by Oliver Glass and his team. Okay.
Okay, great. This actually was my favorite study of the ones that we looked at because, as I'll talk about later, it used different forms of writing rather than just the Pennebaker paradigm of expressive writing. So this was a 6-week intervention study that was conducted by, Mr. Dr. Glass and his team, and they were using a program titled Transform Your Life, Right to Heal. That kind of it was actually created by one of Pennebaker's colleagues, who was the kind of one of the arbiters of this study. And the program included like a writing prompt that was very similar to what Dr. Pennebaker used in his experimental work, but it also incorporated 5 other styles of writing, including what they called transactional writing, which is where they encourage the participant to focus on the perspective and feelings of those around them rather than just themselves. They had them do poetry, where they were supposed to express themselves using metaphors. They had them do affirmative writing, which focused on identifying personal strengths and aspirations. Legacy writing, which encouraged the writer to reflect on what values were important to them. And then mindfulness writing as kind of the last style, where they were encouraged to be kind of aware and attentive, um, and have like kind of a distance between them and what they were writing about so that they could assess and kind of accept the things that they were writing about. And I thought that was so cool. But basically, they had 39 adults who volunteered to do the study, and they had them once a week for 6 weeks come to a location and write out either on a computer or in a journal these writing assignments. Um, and they had them write basically for 15 minutes, 5 minutes in between with these different prompts. So the outcomes that they assessed in the study um, were one, resilience, that was the primary outcome, and two, stress, rumination, and depression symptoms. Those were their secondary outcomes. And they used the Connor-Davidson Resilience Scale, which is a 25-item scale with scores ranging from 0 to 100 in order to look at resilience. Um,
Let me
oh,
read some of these. I think it's really cool. Um, I always like to see how people define things, and hope it's not too nerdy for everyone listening in, but it's like, so they had questions like the ability to adapt to change. Do they have close and secure relationships? Sometimes fate of God can help. Sometimes fate or God can help. Um, so that's kind of like a positive view of the world, right? Can deal with whatever comes their way. Past success gives them confidence for new challenges. See the humorous side of things, and so on. So it's like these are kind of like things that people have found in other studies that have um, been found in more resilient people. So they put together the scale, and it's from 0 to 100. So what did this study find the change was?
yeah, so they found an increase in resilience scores of about 10. Um, and they used the Cohen's D uh, to determine effect size, and they found that it had a very large effect size.
0.75. So think about it like this. The scale is from 0 to 100, and these people went up 10 points, which is like, cool, that's 10%. That's good. Okay. Just in one intervention of writing. That's pretty amazing. What other scales did they use, and what did they find from those scales?
Right. So the secondary outcomes were stress, rumination, and depression. So, or perceived stress. So, in order to measure the stress, they used the 10-item perceived stress scale. That one is scored from 0 to 4 on a 5-point scale, and total score. The higher the score indicates a higher level of perceived stress. And again, the study that we're looking at with Dr. Glass, they found a difference in perceived stress with an approximate decrease of 6.1.
A 10 item scale. So 10 times 4 is 40. So there's 40 points,
Right.
right? So, and a 6 point difference in a 40-point scale sounds good. Awesome. Yeah, Cohen's D was 0.76. So a little bit decreased in perceived stress. All right, what other scales did they use?
Oh, yeah. Okay, so the other scales that they used were so to look at depression, they looked at the 20 item Center for Epidemiological Studies depression scale. Um, and this scale is also like a self-report 0 to 4 scale. Highest possible score is 60. And the team found that depression scores decreased by a mean of approximately 6. And then lastly, they used the 22-item rumination response scale in order to measure rumination. This is also a 4-point scale. Um, and they ask basically about the frequency of each rumination item, one being almost and never, four being almost always, and then kind of questions that are, considering rumination. So, how alone do you feel? How often do you think about a situation, wishing it had gone better? Dimensions kind of like that. And what they found was that the RHS, the rumination response scale scores decreased from baseline with a mean of about 8.6 and an effect size of 0.82.
Probably significant enough to try this. I mean, this is cool. Interestingly, when I listened to one of his podcasts, he said something like, you know, there might be a limit to the effectiveness of this. So he's had some people who like keep trying it over and over again and it's not helping. And he's like, hey, maybe do something else. So if you're listening to this and you're like, Dr. Peter, you don't understand. I write all the time. I'm not getting better. It's like, okay, let's try some other things. Let's try therapy. Let's try exercise. Let's try, you know. So yeah, okay, keep going.
Yeah. Just to kind of talk about what, like, to respond to that, I feel like a major thing that we've learned from these studies is that it really is the population that you're studying that determines the effect that it's going to have. One thing that they mentioned specifically for this study was that all of the participants volunteered to be in the study. So and they did not get any form of compensation. So they were already interested in writing. So that's another like thing to mention, which is like these people who receive this benefit were already kind of interested in writing as a way of therapy. So if you're not interested in writing as a form of therapy, maybe it won't have the same effect on
Well,
you.
I would say try it. Try it. Try
Yeah,
it at
yeah.
least a couple times. Um, no, I think there's something really cool about, a 1 day intervention having a cool decrease in symptoms. Like even if it's 10%. 10% is just a little bit less suffering. We're moving in the right direction. One thing he talks about in some of his other stuff is he talks about some people it doesn't seem to work. And so he has them try different things. Try writing with your left hand. Um, some people didn't even want to write some of the stuff down, so no one could ever read it. So he said, why don't you just write it in the air, So just write it to yourself, basically. Some people enjoyed burning what they wrote afterwards. So,
Mm.
to just be able to write it, but then to get rid of it. So, you know, there's this kind of aspect of there's not one monolithic way to do this. See what works for you, see what works for your patient, and go with that.
Yeah. And another thing I thought was interesting about this study was that they also used a scale of 0 to 10 and they asked the patients to what degree was the writing meaningful and valuable for you. And for every form of writing, the average rating was above 6. So the lowest rating was the poetic style, and that still had an average rating of 6.92. So people enjoyed doing this intervention. People enjoyed doing this writing, and they found it meaningful and valuable.
Yeah, really cool. Hey, I want to jump to your study. Is there anything you want to mention about your study that you did, or shall we leave that for the article write-up?
No, so I can talk a little bit about it. Again, this is like a little baby mini undergrad study. But basically, what we did is we recruited participants from within the college that I went to, and separated them into two groups. So one group did an expressive writing intervention for 15 minutes. This was only one intervention, one day, one period of writing. And the second control group also did a form of writing, but they just wrote about basically their time management skills or what they were supposed to write about, like what they did during the day.
Okay.
Um, and then we used the state trait anxiety inventory, specifically looking at the state anxiety portion, which was created by Dr. Spielberger. It's pretty old. The scale was developed in 1983. And we basically used that. It's a 20-item scale to measure anxiety. So we measured anxiety pre-intervention, post-intervention, 30 minutes post-intervention, and then 15 days post-intervention to see like how anxiety fluctuated between the two groups. And we found pretty small effects, but we did find that there was a decrease in anxiety over both interventions, which we kind of speculated was that maybe people were still writing expressively in our control group. Maybe the instructions weren't clear enough that they weren't supposed to talk about their feelings, because I actually was the person that was reading through all of the
Oh,
writings.
really?
Yeah.
Okay. And what did you find in reading their writing?
That people who were writing about their day would be like, oh, this happened to me today and it made me so upset because my teacher was supposed to do this and I never said that I was going to do it, but then I did end up doing it. And now I'm so annoyed because and I'm like, you are writing expressively. You are confounding the study. But yeah, so we did kind of include that in our discussion, which is that we kind of felt like people maybe were still kind of writing expressively, and maybe that's why they also had a decrease anxiety, but still the effect sizes were very small. The change in their state trait anxiety measures were pretty small, but still
Yeah.
statistically significant. So clinically significant, I don't know, but statistically significant, yes.
Yeah. And I think what one thing that this study shows is it didn't increase anxiety to write.
Right.
Um, some people say like, oh, isn't writing or just ruminating on your problems, isn't that just bad? Like, doesn't that make you worse, more depressed, more anxious? No, it doesn't. If anything, it's going to decrease a little bit. Okay. I think I would like to jump to talking about the physical benefits of writing. Can you talk to me about this study by Joshua Smith in 1999?
Yes, so in 1999, Joshua Smith and his team examined the relationship between expressive writing and physical symptom improvement in asthma patients and rheumatoid arthritis patients. So they had a sample of about 112 patients, 61 asthma patients, 51 rheumatoid arthritis patients, and they had them complete an expressive writing protocol, and then they assessed their physical symptoms. For the asthma, they used spirometry, specifically the FEV1, which is the forced expiratory volume within 1 second. So how much air you can push out in 1 second. They measured that in their asthma patients, and in for the rheumatoid arthritic patients, they had them evaluated by a rheumatologist who looked at symptom severity, distribution of pain, tenderness, swelling in the affected joints, presence and severity of deformities, assessment of daily living capacity, and general psychosocial functioning. Uh, in order to determine symptom reduction in that group. And what they found was those who did the expressive writing intervention, they had like improvements in their physical symptoms. So for the asthma group, they found an improvement in FEV1 from 63.9 to 76.3 at their 2-week follow-up. And then for the rheumatoid arthritis group, they found a global decrease in rheumatoid disease activity as determined by their physicians at the 4-month assessment.
And my first thought was like, well, you know, What if everyone got better? But the control didn't get better. That's what's crazy is like the control group did not get better. And my second thought was like, well, we do writing. So I run this IOP partial program and we do a lot of writing in there. And a lot, especially for psychosomatic patients who can't verbalize emotions, sometimes they can write emotions. Sometimes they can like start to be congruent, talk about how they really feel, what's really going on inside of them in writing. So I'm like, okay, yeah, maybe that's part of the success in these patients who had a little bit improvement in their physical symptoms. That's kind of cool.
It's interesting. Another thing that they found was that there was like a difference in the time frame in the improvement for the asthma group versus the rheumatoid arthritis group. So they were kind of talking about in the discussion how that could indicate that maybe there's a difference in the mechanism for different like chronic conditions and how writing affects it. And so I thought that was interesting too. I think next probably going to talk about stress and the kind of endocrine system response to stress, um, and also the immunological response to stress. So it's like there are different avenues by which expressive writing or stress reduction or rumination reduction could be affecting physical symptoms. As we talked about earlier, like the change in cortisol, it could be um, different for kind of different disease
Right.
mechanisms.
And it's not a change in a singular thing, right?
Right.
And cortisol, just salivary cortisol, is a really poor indicator in my mind of stress, of what's really going on because, there's so many fluctuations of that throughout the day. Um, there's so many different inflammatory markers. But I think the big point is that if you can reduce stress, if you can reduce rumination, if you can reduce anxiety, yeah, your body calms down. I've patients will in some way get some symptoms from stress when stress is beyond the capacity for them to deal with it. They'll get migraines, irritable bowel, fatigue, fibromyalgia, pain will increase, inflammation will increase. I have a friend who's like joints swell up when he gets stressed.
Yeah.
Um, and for a while I was like, man, I think you have rheumatoid arthritis. Eventually we learned out it was gout. So he has gout attacks when he gets stressed, you know, because gout is from like cells breaking down more than usual in the body. And when you get stressed, maybe there's more apoptosis, cells breaking down. So, okay. Yeah.
Yeah, kind of personal story there.
Yeah,
I
go ahead.
I get pretty bad dyshydratic eczema on my I don't know if you can see it on the camera now, but I get pretty bad dyshydratic eczema and it flares up a lot when I'm stressed. So like when I was studying for step two just a couple of weeks ago, like my hands were literally falling apart. Like they're
Oh,
yeah, it was bad. But
wow.
now it's a lot better. I've been using cortisol cream as well, so that kind of helps a lot. But yeah, I can definitely have some firsthand experience. My body definitely responds to stress very physically. So
Yeah, what was it like? I know, so when you started this, I was like, why don't you do this? Why don't you try to write? Let's talk about what that was like for you.
yeah. So first thing is I have tried journaling in the past and it's always been hard for me because I just have a hard time sitting down and focusing and doing one activity. And I've just always kind of been like that. I have not been officially diagnosed with ADHD, but I have been referred to be diagnosed and I just keep forgetting to do the appointment. But I don't know. I don't know why. I
Well,
just always had a hard time just like sitting down
I
and
I felt that too when I sat down to try to I did this with you actually.
Mhm.
I was like, oh, I should check my email or oh, I need to like, you know, pull up my social media or there's all these like little distractions, or like so it's
Yeah,
just it's hard to sit there for 20 minutes. It really is. But I
it's
did it because we
it
were
was
doing it for this podcast. So,
right.
okay, go on.
It was for me, it was hard just to get started. Like it was hard to get myself to, okay, sit down, I need to lock in, I need to do this. But once I actually did get started writing, I felt like the time passed so quickly. And then by the time the timer went off, I was still like had a bunch of things I wanted to say. And for even one of the days, I just continued writing anyway because I was like, I just want to get everything out. Um, but yeah, I found like it was very it definitely showed me some areas of congruence in my life. where I can see how my past traumas have kind of affected me now and how I respond to situations now, how I build my self-talk now. And I kind of talk about this at the end of the article, and all of the studies and protocols we've looked at, they've been looking at how people experience like symptoms weeks and months kind of after the intervention. But I would say even immediately after the intervention, I felt a little bit better. Just a general sense of betterness, like I got something out, I released something, you know. And that's kind of what we found too in our study. We had them when we studied anxiety, we had them do a retake the anxiety inventory 30 minutes after writing, and that's when we found the largest decrease in
Interesting.
it, which and it came back up after the 15 days. But
Yeah. Yeah. I was expecting to be distressed after writing. There was some, it's like I had anxiety to sit there and write about my anxiety.
mhm.
Um, but then afterwards I was like, okay, wow. Yeah, that was really powerful. That was really good. That didn't stress me out. That made me feel better after. So I don't know what it is about, like there's something about trauma we want to avoid talking or thinking about something traumatic, but to actually go there, it doesn't make it worse. And that's one of the things that this study, all of the studies that we read found, right?
Yeah.
Okay. Yeah. Any other big things jump out to you in this experiment?
For my personal experience, you're saying?
Personal experiment. Yeah.
Um, I guess I also was a little bit surprised about what I chose to write about. I didn't really talk about this in the article, but I've had like a couple of different things happen in my life. I mean, everybody does. And I think the things I wrote about were probably not from the outside perspective, things that people would consider to be like the most traumatic things that have ever happened to me. But they were things that I felt like I was still being impacted by to this day, if that makes sense. Because a lot of the stuff was more like emotional traumas rather than like like I've been in like a pretty bad car accident before when I was younger. And I didn't, but that hasn't affected me emotionally as much as like much smaller things that occurred when I was maybe like in high school or middle school or stuff, like things that still kind
Yeah.
of my self-concept to this day.
Well,
So
don't negate how important those things were just because they were emotional, you know? I think they of course they could be a big deal and of course it's important to
that's true. That's
yeah.
true. But I think like it just showed me that you don't have to be like a severe PTSD patient in order to have find benefit in writing about your trauma. Your traumas can be small and you can still find benefit or small, however you define that, and you can still find like a lot of emotional benefit in writing about them.
Hmm. Yeah, absolutely. I would agree with that. I would agree with that. I think I would say to you, I would reiterate this idea that like at times we can feel like some of the things that happen to us, we should not feel very distressed by them. And like, and I think no, it's okay. It's like it's there for a reason. Maybe you don't fully understand why it was distressing as much as it was, or maybe, how can we have some increased compassion for like, a particular thing did really awaken emotion and distress in us in ways that we didn't expect. Um, so yeah, I would kind of reiterate that for you and for the audience as well as you endeavor upon writing about distressing things.
Hmm. How did the intervention go for you in terms of like what you felt like you wrote about and
It it went well, and I think I need to continue it. So I need to like create the discipline to like be like, okay, this is important. I'm going to spend 20 minutes. I get up pretty early. I'm just going to spend 20 minutes and keep going. I actually wrote some poetry as well. So I wrote just freehand. I wrote some poetry. It just came out, so it's like, um, yeah, I wasn't going in with like an agenda. And I think some new thoughts came out to me that were kind of circling around. And so that was helpful to kind of connect things that were maybe a little bit less connected in just my verbal. mind thinking, to put it down, connected it. You know, personally, I wrote it. It's very personal. I don't want to share it. I won't share it
Mhm.
with anyone, and that's okay. I think that's actually better is to write in such a way that it's like there's nothing you're not fearing some future person reading this and therefore restricting what you're going to put down, right? So,
Yeah, Dr. Pennebaker actually talked about that in kind of an interview I had watched with him, where he said that he suggested basically that people write with, I think you talked about this earlier, write with the intention of like burning or throwing away whatever you write, that you do have that kind of like freedom of expression.
I think that's good. Well, thank you so much for working on this with me and doing this project. And I think your write-up is awesome. I contributed a little bit. We talked a lot the last couple weeks about research and about how to read articles and stuff like that, but you did a wonderful job pulling together some of the key articles on this, and it will be on psychiatrypodcast.com. You can we'll write some continued medical education questions so people can get some CME for it. And yeah, it's great. Thanks for coming on.
Thank you so much for having me, Dr. Peter. I've enjoyed this past 2 weeks, and I don't love research, but I definitely have gained some really valuable tips for learning how to read research and be kind of competent in that field in the future. So thank you so much.
Awesome. All right. Well, I hope if people are listening in who have maybe not read research articles that much before, as they've listened to more and more episodes from me, maybe they gain an ability to sort of think through how to read them, how to think, is this clinically relevant? What can I take from this and apply it? I'm personally taking this idea that this could help most people, but probably the most people, that the highest percentage that will be helped the most is people with some level of dissociation. And I'm actually going to get a PDF of that dissociation scale. And if I think someone has dissociation, I'm going to have them do that scale to kind of see what it looks like as well. So that'll become part of my process coming out of this episode. So thanks for changing my practice moving forward, Emerald. All right, we'll leave it there for today.